What is the mission of the Federal Electronic Health Record Modernization Office, also known as the FEHRM? How does this office work to meet its mission to implement a single, common federal electronic health record? And what are some of the key implementation challenges faced by the FEHRM? I'll explore these questions and so much more with my very special guest, Bill Tinston, Director of the Federal Electronic Health Record Modernization Office. So, Bill, the mission of your office is to implement a single common federal electronic health record, EHRM, across multiple agencies, including the Department of Defense, Department of Veterans Affairs, the Coast Guard, and NOAA. In fact, I was hoping you could take some time and describe how this mission enhances patient care and provider effectiveness, and what makes this unified approach so critical.
Well, if you think about what we're doing with veterans and military beneficiaries, Coast Guard members, NOAA members that are covered, federal healthcare beneficiaries, they're very often the same people, regardless of the department that is supporting them, whether it's Homeland Security or whether it's the VA or whether it's DOD. It's the same people we're talking about in many cases. So what we're able to do we're able to do a couple really major things and set us up for a future that was unimaginable just 5 or 10 years ago. So the first thing we can do is we can simplify and take the best of healthcare delivery processes within any of those departments, like DOD, who was first out the gate and has completed their deployments. They were able to standardize within the department how they eliminate unwanted variation in how they delivered care, right? So it's not that there can't be variation. It's that you can manage the variation. You can also promulgate innovation in how they deliver care very quickly. And you have that same information about any individual, any patient, any beneficiary at any military treatment facility that they visit at a moment's notice. So, if you move from the Pacific Northwest to the Southeast United States, you no longer have to carry a record around or a paper record or hope that somebody else takes care of it, because it's one database, one record about the patient, not who delivered the care or where the care was delivered. And then that carries to these same people when they leave the DOD and they become veterans. And if they choose and become use the VA medical system, the Veterans Health Administration, that same record is available to the providers at the VA across the entire VA. It's not stovepiped to a particular VA medical facility, DOD medical facility, or even medical system. So we take that a step further, and I think you'll probably ask me about this later, but I'll tell you now so you get the big picture. We put a lot of effort into interoperability with the community health system as well, right? So we have become DOD, VA, Coast Guard, NOAA, future partners in the Federal Electronic Health Record. We have become the largest exchanger of health information, I believe, on the planet, and certainly in the United States, and certainly with all of the major regional exchanges that we're connected to in the Joint Health Information Exchange. And we do that together. VA doesn't do it, DOD does it, NOAA does it, and Coast Guard does it. We do it once. So if a request comes from Inova, Kaiser, any of the systems out there for information about a person who's been seen at any of the participants in the Federal Electronic Health Record, we can respond to that. And likewise, if anybody, a provider in the federal network requests information, it goes out to all of the electronically connected health systems in the country and brings back the information so that we create, in the end, probably the most complete record that anyone has imagined creating about the longitudinal record about the person who's being served by the Federal Electronic Health Record. So that's why it's important. And in fact, think about it. I was a military brat. So I was born in the military health system. My father's a veteran. My brother's a veteran. But I didn't actually join the military. But if I had, I was born into the system. And I could spend my entire life in the DOD and the VA military or health system from a beneficiary perspective, through the cemetery at the VA, from birth through the cemetery to end of life at the VA, all in with common information shared across the departments, putting the person at the center of the experience instead of, there's a lot of talk about that, right? Patient first, patient-centered, user-centered design. the key there is we have to remember that we really mean user-centered or patient-centered. We don't mean user-centered or patient-centered after we put a lens of technology and organization on it. And it's user and patient-centered as long as it's aligned with our organization and our technology. We really want to start at the patient and make their experience as seamless as possible.
That's a great segue into my next question around, and I think you kind of alluded to the answer there, but putting the patient first, using these tools like user-centered design. But can you give us a sense of how creating a digital first infrastructure, how can they work together and be complementary so you're fostering better patient outcomes and improve efficiency for the healthcare provider? How do they work in tandem and not in tension?
So it does, absolutely. And it's one of the reasons that the DoD and the VA had the insight and foresight to create the FEHRM, right? They were creating a single record about the patient, but it was being driven by organizational and legacy technology requirements. What they've created in the FEHRM to support all of the participants in the Federal Electronic Health Record is really a clearinghouse and a conscience of putting that patient first, making sure that we converge workflows and processes where appropriate. It is not always appropriate, and that's clear, but where appropriate, so that we simplify the patient experience for the patient, for the people, for the Americans that we serve through these health systems. We had a major achievement last year where we delivered the only truly integrated DoD and VA facility, which is James A. Lovell Federal Healthcare Center in North Chicago, Illinois. They serve veterans and military beneficiaries alike, as well as the Navy Accessions facility at Great Lakes. So all the new recruits that are coming into the Navy, right? So that's their beneficiary base. And we brought the electronic health record there so that they could deliver the integrated experience that they need for these young men and women who are coming into the military through their retirement and into their veteran experience in a single record. And that's the first place we've done that. And that really unlocks the ability for the health systems to support one another and from a patient first, user first perspective going forward. So you improve the access to care, right? If you have the information about the patient and you know where appointments might be available that would meet the need of the patient, then it's incumbent upon the people that run the health systems to make the decisions to make those appointments available. If you have more facilities in the DoD than you do in the VA, or they're better situated, but you have more providers in the VA, how do you work together to get the providers in the facilities so that the Americans that we're supporting get the care they need? Well, you do that through technology. You enable it by creating a single longitudinal record about the patient that can be shared wherever care needs to be delivered, irrespective of who's delivering the care, organizationally, or the specific provider, or the location that care is being delivered, right? So the whole thing with a record is sharing information to an encounter so that the clinicians have the information they need to give the best care that they can to a patient. So that's getting it to where it needs to be in front of that provider about the right patient. And then capturing the information from that encounter so that it can be used in future encounters and managing that patient's care going forward. So it's the technology brings us to a place that we've never been before in sharing that information. We've had a couple conversations about this recently, right? Because we all take, as a technologist, as a clinician, whatever your role is in this, as an administrator, we all start with this: how do I, as a technologist, deliver better technology to this system to create some outcome? But what we've done here by getting, and that's wrong. It's important and it's a good start. But what we've done here is we've created a sense and a commitment to look at the patient first and then work together across multiple massive health systems to simplify, streamline, and maximize the quality outcome of that patient experience. That's all enabled by the technology. And frankly, the commitment to doing it that you've seen the secretaries of both the DoD and the VA talk about publicly on several occasions. They put out memos that they want to work together. They want to create the best care experience and the best transition experience for the military members as they become veterans and get to go through their veteran experience. You probably have another question, but I did want to say this. I think it's important. I steal this line from a coworker at the Defense Health Agency all the time, but he said once in my earshot, and so I repeat all the time. Over here at DoD, we sort of create veterans, right? I think that's key, that we understand and recognize that we're always talking about the same people.
What are your top strategic priorities for the next few years, particularly as you prepare for the resumption or the reset for VA and others happening? So where are you focusing your time?
We're focusing our time at the firm right now on anything we can do and anything we can enlist others to do to make the VA successful at completing the deployment of the federal electronic health record. Doing that opens up, as I was just describing, the door for better coordination and operational interoperability between the health systems. But it also opens up a world of opportunities from a technology perspective. You hear a lot of people talking about AI, and you can Google it, and any quick Google will show you quotes on AI, and I think 100 of them. The first one I heard say it was Larry Ellison at Oracle World a few years ago, but I have subsequently looked. I think I was looking for the exact quote. I was like, whoa, wait, every senior technologist on the planet has said this. AI is only as good as the data, right? What have we done? What are we doing? We are creating the greatest store of healthcare data on the planet. We are creating a longitudinal record of the lifetime of the Americans that are being served here. We are creating the most complete record that's ever been envisioned, right? When you look at our connections to the community healthcare system. So what does that enable? Well, it enables a lot of things, but it enables a very comprehensive set of data that allows you to use tools that I haven't even imagined, and probably a lot of people haven't imagined, to provide better care and better insight into the health of individuals. It also gives you the opportunity to use that same data appropriately for research and insight into population health. And I was talking to some people recently, and it was a technology conversation about healthcare. And one of the people said, sometimes technology solves your problem for you. And the context was that we had spent a lot of time on working on how to define roles in the DoD, but as technologies improve, that's less important. And so, the guy talking was like, but that doesn't mean we shouldn't have been doing what we were doing. We did the right things, but sometimes technology overcomes the problems you have and makes them unimportant, trivial, minimal. And so what struck me, having been the PEO on the DoD side, that's Program Executive Officer on the DoD side, there's a program in DoD called JOMIS, which is all about operational medicine. What does that mean? That means deployed medicine. How do you I said earlier that this is all about how to get the data to the people that need it about the person they're seeing, and then capturing data for future use, regardless of the environment. So people are deployed. How do you do that? Could be a classified environment, so you got that restriction. Could be low or no comms. So those are the two biggies. But how do you get that light footprint? How do you deliver that? That's a big problem. They've spent a lot of time in DoD talking about that, and they still are. And interestingly, there's huge implications as they deploy that to use it elsewhere in rural care and natural disasters, man-made disasters, emergencies, whatever. But this conversation went to the point where we were talking about the Coast Guard ships. How do we deploy these capabilities to Coast Guard ships? Because they're looking at how they do it for the Navy. But for the Coast Guard, do you know how they're doing it? Starlink technology has overcome the problem. You now have connectivity. It is not a no or low connectivity environment anymore. They put Starlink on the ships, and they can use the software as it is because they have the connectivity they need.
I want to get back because you've mentioned a couple of times the Capt and James Lovell Federal Healthcare Center and the joint DoD VA implementation. I was hoping you could share with us specifically some of the key lessons learned from that deployment, and maybe put a fine point on how it's shaping how you approach future implementations.
Yeah, this is going to be slightly redundant, but I appreciate the question because I think DoD and VA accomplished something at the James A. Lovell Healthcare Center that I know from the 2 years running up to it, I heard a constant barrage of "that's impossible, you'll never get it done." And they got it done. So James A. Lovell Federal Healthcare Center is a unique facility in the country where many years ago, 15 years ago or so, I think they needed a new Navy hospital up there and they needed a new VA facility up there. And Congress and important people at the time said, hey, let's not do that. Let's build a joint facility. And the director's a VA employee, but they have uniformed military personnel there as well. And they serve the DoD and the VA communities with an integrated staff and integrated operations. But what happened at the time was they said, we're going to do this. It's a good idea. We're going to build one brand spanking new facility. We're going to deliver great care in an integrated fashion to these constituencies. And the team up there did a fantastic job. There's no knocking what happened. They did exactly what they were asked. But we kind of, and I say we, I wasn't part of it, and I don't know who was part of it. We did it in this two systems way. We didn't change the IT. We didn't give them the integration. I mean, it was as basic as they couldn't see one another's calendars because some of them were on the DoD implementation of the calendar and some of them were on the VA implementation of the calendar. They used the Vista record. They used the DoD record, the Alta record. So they were all over the place. And they had people integrating the processes, right? And they did a fantastic job. So in no way do I want to give the impression that they did anything but a fantastic job, because they did. But we put the burden on the people that administered and delivered care there to make that all work. And so they stepped up and they did it. So what did we do at North Chicago? What did they do for themselves at North Chicago? We delivered the single electronic health record to them. So they no longer have two. In the process, they recognized for a long time, but they were heard in the fact that the administrative tools that they had weren't effective for them either. The email, the Microsoft tools that we're all accustomed to using. So the two CIOs came in and they found a solution with Microsoft for that. So they operate as an integrated team. They have integrated tools. They have an integrated record. So that's really awesome for them. And they drove a new baseline for the Federal Electronic Health Record that supports integrated operation for DoD and VA. So I'm going to pause there because I want to emphasize that. We created a baseline. They created a baseline at North Chicago that allows for the integrated operational integration between DoD and VA. So that is something that can be used, that configuration, refined as we move forward. That configuration can be used in other locations where we share services or future locations. So it really unlocks the potential of the two health systems. Now, I'm on the IT side. These aren't my decisions, and I'm glad they're not. But it unlocks the decision space for the people that run the Veterans Health Administration and the people that run the Defense Health Agencies to decide how they support one another with facilities and staff, and put the focus on the patient and the people, improve access to care, because they're not limited by what the IT allows them to do. So that's what was important about, well, there's a lot of things important about FHCC, but I think that is the biggest takeaway from what was created at FHCC. They led it. It was done for them. How did we get it done? We all took our badges off and we were Team Lovell, Team FHCC. The contractors worked together, even though it was, Oracle and Leidos as two prime contractors. The health systems worked together. And we all took the lead from the director and his team at FHCC and how we create a single system, a set of workflows that support the integrated operation of their DoD and their VA components. It's a weird place. Like it's the only VA facility that has Well, I mean, they'll tell you when you go there. It's a fun place to go. Um, they're the only VA facility that has pediatrics, right? Because VA doesn't do pediatrics generally, but they do there because they see VA or DoD beneficiaries as well. So there's a lot of strange things and a mix of what the two departments beneficiaries receive that are integrated there and delivered there. And actually, I had an interesting experience one time when I was visiting. I was in what was effectively a Navy clinic or a DoD clinic up there. I'm talking to the guy running the clinic in the background. And he's like, oh, and this is before we deployed. And he said, oh, I can't wait till we get on the new record because DoD had deployed every site except there. And he said, they keep turning off the old system on me, telling me that nobody uses it anymore. I'm like, but we do. So that resolved that problem. But that was an extraordinary experience to see two departments, honestly, because the DepSec of the VA and the personnel and ready undersecretary for personnel and readiness took personal interest, made multiple visits out there, and made sure that the departments and the programs and the health systems were putting the users and the patients first and creating an improved experience there. And if you have the opportunity sometime to talk to Dr. Buckley, who runs that facility, I think it'd be very instructive. I mean, he doesn't love everything that happened, and he's not shy about telling you what he doesn't like. But he will tell you that he's in a better place than he was before and feels like he's in control of what was created there and doesn't always get what he wants, but has a voice in how it changes in the future and is in a better place than he used to be.
Bill, I have so many questions for you, but I want to make sure I get to a couple of more before I let you go. And one of them is around the Joint Health Information Exchange and around the topic of interoperability. How is this initiative evolving and what impacts is it having on the care delivery and navigating between federal and community providers? Can you give us insight?
Yeah, I can. You know, the future is interesting. Technology solves problems that you put a lot of effort into. So we'll see where we end up. And we got TEFCA and QHINs and the work that they do at ONC, but they're not called ONC anymore. Anyway, they set groundwork that makes all of this possible for interoperability with the community healthcare and the DoD healthcare. But when I first got involved, things had been going on for a long time. Well, actually, let me back up even a little bit further. When I talked to Dr. Evans, who runs the VA implementation at this point, he's a provider. He sees patients at the DC medical facility. I've heard him on several occasions say, hey, look, we've always had access to data. It's just we had to use fax machines and phones. So it's not like we couldn't get data. It was difficult. It wasn't readily available. It took time. It took time away from thinking about the patient and dealing with the patient. So we've always had access to each other's data in one way or another. When I got involved, we had the regional health exchanges existed and the national health exchanges existed. VA and DoD operated independently. And I actually remember the numbers. I was on the DoD side then. I think DoD was connected to about 14% of the community providers out there, and they focused on where they thought they had a big impact. And VA was much higher, and I think it like 40% that they were connected to. And it was two efforts that were run separately, so very duplicative. And at the same time, they didn't support one another because you had to connect to DoD and VA independently. So we created the Joint Health Information Exchange, moved that to the Federal Electronic Health Record Modernization Office here, and combined our efforts into that single Joint Health Information Exchange. So we are now connected to every, I have to be careful about this, every electronically connected system. There's always people that aren't connected for one way or another through all of the national exchanges. And the guy that runs this for me in the firm showed me one time. He goes to some regular discussion with folks, and they put up a chart about, a bar chart about transaction volumes from each organization that is in the exchanges. And they actually had to take VA and DoD out because it's so dwarfed everything else that their bars didn't come off the baseline. That's how much data DoD and VA and NOAA and Coast Guard exchange. It is extraordinary, the information that is exchanged. So what are we doing there, and what's the future of that? Because we are connected to just about everything, and we follow TEFCA. We're evaluating QHINs. We're going to see where that goes and which QHIN we sign up with. But as we go forward, what do we do next? Well, we're looking at things like seamless exchange, which is a technology coming out of Oracle, and I'm sure there's others, but this is the Oracle. The core of this is the Oracle Health software, where we dedupe the data, bring provenance over, and from trusted sources, we ingest that information after deduping it, so it's dramatically reduced into the record itself. So right now, that's done with a provider in the loop, right? We can bring information from community providers into the Federal Electronic Health Record, but there's a provider in that loop. So as we're working, and VA is piloting this at the moment, and we'll see how it goes, and we'll deploy it across VA and DoD as appropriate. But it'll bring that information in, and I'm repeating myself, but it bears repeating. We are creating the most complete record about a person's health that's ever existed. So then what do we do? What's important? So I think it was my second week involved in this healthcare space. I was talking to a doctor, and I had just absorbed how important it was to have all the data about a patient available to a provider when he was making decisions about, he or she was making decisions about what to do next and evaluating a patient. And so this guy looked at me, don't remember his name. He was an Air Force doctor. And he said, yeah, well, Bill, take some of that with a grain of salt. I care less about your broken leg when you were 12 than I do about your current lifestyle issues, right? And I'm like, okay, so it's not all as relevant or important. So how do we now, and this is where some of the AI stuff comes in, and this is where we're using some natural language processing tools to do this. How do we now take the intellectual burden off the providers and going through this avalanche of information and find the relevant and appropriate information and present that to them as we go forward, right? Because it's not just about having every bit of information that's ever existed about a person. It's about getting relevant and appropriate information in front of a provider who's using their brain to evaluate and make decisions about what to do with a person in front of them. So one of the big issues we have is that we present too much information. So that's one of those opportunities going forward. So we're taking short-term steps. We're looking at data duping. We're the seamless exchange. We're bringing more in, but that's one of those opportunities and we're bringing in natural language processing. But then that's one of those opportunities for AI. How do you really evaluate either the breadth of that information or bring it down to the relevant pieces so that you simplify the intellectual task on the provider?
This has been the Business of Government Hour, a conversation with Bill Tinston, Director of the Federal Electronic Health Record Modernization Office, the FEHRM. Be sure to join us next time for another informative, insightful, and in-depth conversation on improving government leadership and its effectiveness. Until then, subscribe, download, and listen to the entire interview at Apple Podcasts, Spotify, Audible, or on your favorite podcast app, and as always at businessofgovernment.org.